I'm Simon Lewis. I thought I'd introduce myself first and tell you why I'm here, and then we can ask some questions later on. I'm been in pre-hospital care since the year 2000, so like many of you, I'm a reasonably experienced pre-hospital provider. And the aim of this session, actually, for me, is to build on your pre-hospital experience. I'm currently a consultant in emergency medicine. I call myself a consultant in pre-hospital emergency medicine, but I am not subspecialty accredited. So I'll put that there first. I haven't been through the training, so that's debatable whether I should be calling myself that. However, I'm a consultant, so I supervise. I've supervised trainees. So, like yourselves, you've all got experience of supervising. The day is about building on both of those things, your pre-hospital experiences as a provider and your experiences as a supervisor. I'm actually, if you look at the bottom here, the training programme director for Health Education England, working across the east of England for pre-hospital emergency medicine. And that's why I'm here. Because all the training programme directors come together and sit on the training committee of the Intercollegiate Board for Training in Pre-Hospital Emergency Medicine, a bit of PHEM, as it's called. I thought I'd introduce you to this because it's actually quite useful to know the structure around you before we go on to preparing you for the training. So the Intercollegiate Board consists of all the interested colleges and other advisors. It's chaired by Rod Mackenzie, who you'll hear from later on, and has 3 subcommittees: a training committee that I chair, an assessment committee that Phil Hyde chairs, and a curriculum committee that Nick Foster chairs. All of this is hosted by one of our parent colleges, the Royal College of Surgeons in Edinburgh, and that's the Faculty of Pre-Hospital Care there. So the Intercollegiate Board is essentially a collection of your colleges that agreed the curriculum and the assessment framework. That was approved by the General Medical Council, the GMC, and then we have it in approved training programmes. These bodies, whichever country you're in, Health Education England, the Wales Deanery, NES in Scotland, or the Medical and Dental Training Agency in Northern Ireland, are responsible for quality assuring the training programmes set up in those areas. Okay. All to the same set of rules, essentially. So I work for one of those, as I say, with Health Education England over in the east of England. Now, this is all about training and trainees, and I will mention at this point that there is a PHEM Trainees Association. You'll probably hear a little bit more about that later on, and Scott was our first chair of that, and Camilla is our current chair at the back. And they are also hosted by the Faculty of Pre-Hospital Care up in Scotland. So most of what I say today is actually on this website, the Intercollegiate Board website, ibtfem.org.uk. If it's not, there are links on there to email addresses to myself and other speakers, I'm sure. Please contact us, use those details on there. One of the most important things on there is something we're going to talk about a little later on, is the curriculum. So the guide to training on the left-hand side of your screen, the pink guide, the latest version in 2015, contains essentially all the rules for training and the curriculum that we train to. Also available is an Excel spreadsheet that your training programme directors have that normally distribute to the trainees of the curriculum that you can manipulate. If you're very good with Excel spreadsheets, that's not me. If you're very good with them, then you can manipulate this, but actually it's already themed into different phases, different themes, and so on. So actually a really useful tool when we're looking at different parts of the curriculum. So those are the resources out there that are appropriate to this part. Now, we've got a real opportunity, and you have a real opportunity. 2 main things. You've got a 1-year opportunity with the trainee that comes into our training programme, to share with them your experiences, to guide them through training, to get them to meet the curriculum needs, and to get them through their assessments. A 1-year window in which to do all of that. And it is a great opportunity, actually, because the second thing is I guarantee that every trainer that takes a trainee through will learn something. Whether it's something about that trainee or whether it's actually something of the curriculum, because when you look into this curriculum, we've all been PHEM providers probably for quite a while. You'll find that there's some areas that we're less comfortable with, some areas we're really uncomfortable with, and some areas we may well not know anything about at all because we've been organisation specific. So take the opportunity as a trainer and as a supervisor actually to develop yourself alongside the trainees, and don't be afraid to actually say, actually, I don't know, I'm going to look that one up, I'm going to find out more, I'm going to come back to you, and we're going to learn through this together. You'll be respected for that, I'm sure. So please, take the opportunity. This is really a good opportunity, and think of it differently. And that's what we've aimed to do in the whole of our PHEM training through the subspecialty process, is think about this differently. Really focus on training, not necessarily service provision, training. And with the partnership that most training programs have with charity providers, that makes that more possible. I want to take you back and just give you a brief overview of, as John has asked, the training and the curriculum elements, and start at the very beginning, the people that you're going to get and what they go through. So first of all, they're all senior trainees. So the earliest they can apply is essentially ST4, to start in ST5. Many of them are actually also post-CCT. You can apply post-CCT to do this training. As long as you're from one of the 4 parent specialties, which currently are anaesthesia, acute medicine, emergency medicine, and intensive care medicine. You have to meet the minimum specification, which is currently slightly different for some of the specialties, and we're working on aligning that for the 2019 intake. You have to meet, so they are senior trainees. They've got a lot of experience behind them. They will do a minimum 6 months of emergency medicine, 6 months of anaesthetics, and if you're in 2 of the specialties, you will have had to do 6 months acute medicine and 6 months intensive care medicine as well. So don't forget that they're senior. They've got a lot of learning behind them. And they have to go through a national recruitment process. So the only way in to PHEM training is through national recruitment. There is no local recruitment for this. And it follows a pattern, and I'd really encourage you to get involved. Online applications open normally beginning of October for the following August and February posts. So this year, in October 2017, we'll be recruiting for the August 2018 and the February 2019 posts. The selection centres run currently by Health Education East of England, over in Cambridge. And after a shortlisting and long listing process, the selection centre over in Cambridge in early December. Excuse me. So that's your opportunity to get involved, because actually we look for people from across the PHEM subspecialty world to be part of the recruitment process in the National Selection Centre. There they have a standard interview and a scenario, and that scenario, all the details are a part of the recruitment pack. They're available on the Health Education England recruitment website. Based on that, they get a ranked outcome. The trainees will rank in order of preference the places that they will consider going to, and then there's a matching process. So by essentially the middle of December, trainees should know where they're going to in the following August or February. And soon after that, once things have been confirmed, your training programme directors will know who's coming to you about 6 to 8 months ahead. I want to share with you some of our learning as we go along as well, because I think it's really important, not just a sort of straight run through of what we do. What we found, what we didn't really realise, was that these are senior trainees. They're often settled with families, some even have mortgages. They're really settled in an area, a region, because they're ST5. Because of this matching and ranking process, they could move to a different country. So we have trainees moving from Scotland down to east of England. You can be in the southwest, coming from Scotland, similarly going from there. The travelling, the displacement and the anxiety that can create is quite significant. So really bear it in mind, and if you're allocated someone as a supervisor early on, your TPD will no doubt be in touch with them as well. But just be aware that there's some anxieties around moving. There may be some physical, logistical issues. Emotional issues, actually, family attachments. How are you going to alter their shifts to balance this? Just be aware when you're dealing with them as a supervisor that if they're actually commuting back to their home to be with their young children at the end of their run of 3 shifts and then coming back 3 days later, that has an impact. Bear it in mind. So it wasn't something we necessarily really expected. They get to choose from the approved training programmes. You'll see on the screen all of the current approved training programmes. In fact, the only ones we haven't got in a region at the moment are in the East Midlands, the North West and Northern Ireland. So otherwise, there is a PHEM training programme in most areas, which is great. So trainees, when they do put down, if they come to you for your advice about recruitment, which areas they're going to go to, just tell them about where they're going to move to. And if they're not really wanting to move from Devon up to Scotland for a year, and all that that implies, do not consider it and rank it as a preference on your recruitment. So these trainees then start. So what is the training about? Well, we're going to go into what it involves, but actually, this isn't about organisation-specific training. This is about meeting the requirements of the PHEM curriculum and the assessments. We've worked for a long time, most of us, in organisations, and we do this already in my emergency department. There are some things that our emergency departments don't cover as part of the curriculum. Some of our anaesthetic departments won't cover specific areas. You'll have to go and do your cardiothoracic anaesthesia in a different area. Well, PHEM training programmes are no different. This isn't about the organisation I'm in currently. It's about meeting the needs of the trainee across the whole curriculum, which might mean going out and getting experience elsewhere. And some of the programmes all have shown that they can meet the needs of the curriculum and do it in different ways, whether that be via mountain rescue teams, inter-hospital transfer teams, but different parts of the curriculum are met in different ways. So please, this isn't about your current operation. It's not about your organisation. It's about the whole curriculum. And wherever you are, this shows how far I've come down this route, doesn't it? The Gold Guide is your guide to everything. So if there are, this is proper training now. This is PHEM subspecialty training within a structured GMC system. So we have to abide by the Gold Guide. That is your rule book. Go back and look at it for all the guidance around that. It makes it professional for us. That's what we're aiming to do through this training. So trainees get a choice at the ranking stage of which schemes they want to go into, and they will know whether that's a scheme A, a scheme B, or a scheme C. And this is where our training is slightly different to other hospital trainings, and sometimes makes people's ears bleed. So the 3 different schemes, the one that people are most familiar with is a scheme C. So whatever you do, you have to do 1 year, whole-time equivalent of PHEM training, 1 year. And scheme C is that. So it's full-time over a year. You may rotate through different bases, operations, do different things, but it's 1 year full-time out of your training. Scheme B actually says, I'm going to do it in 2 6-month blocks, but in between, I'm going to go back to my base specialty. And you could do that in any order. So you could do 6 months of PHEM first, followed by 6 months of your base, followed by 6 months of PHEM, or you could do it the other way around, do 6 months of your base first, then do 6 months of PHEM. And for those of you that organise rotas, that's how you make your rota work. Scheme A is our preferred training scheme from the Intercollegiate Board. And this is a blended training scheme. So over 2 years, trainees will do a year's whole-time equivalent of both their base specialty and PHEM. And they will blend them together so that you're actually in different patterns, maybe 2 weeks of PHEM, 2 weeks of your base specialty. It may be a month PHEM, a month of your base specialty, keep on going like that. And then we started off actually in a very complex 80%, 20% split. And that was essentially what we're aiming to do in the blended is keep exposure to your base specialty, because we know that skills can fade and that's what trainees have reported to us through the pilot studies, but also try and replicate what you're likely to do as a PHEM consultant when you're actually out there doing the job, which is there are very few people that are expected to be doing this full time. You're unable to revalidate properly in your parent specialty. So actually doing 1 day a week was the norm at that point out of 5, which gave you a 20% PHEM to an 80% base specialty. The percentages are meaningless. It's actually about just blending the two together. And to make this work, you obviously need 2 people on a rota line that just are opposite each other. So that's our preferred training scheme. And actually, some of the trainees may talk about this later. We found that when we've asked trainees, then the majority prefer the Scheme A. If you ask them afterwards what they'd like to do, then again, actually, the majority would think about Scheme A. Things to watch with Scheme C. It's a very, very compact training programme at that point, and getting through 2 summative assessments, as you'll see, in that time period, whilst trying to achieve all of your elements, is quite tight. You really need to keep an eye on them. There is little chance to catch up with a trainee, particularly one that may be a trainee with differing needs, okay, which we'll talk about this afternoon, and we'll share that experience. So just watch out for that Scheme C. It's quite compact. They will choose one of those training programmes, the A's to C, and whichever it is, your training is split into 3 phases. Phase 1A, your initial training, which lasts for a month. Phase 1B, which is called our developmental training, for 5 months. And then your second 6 months is your consolidation phase. Okay. So what I'd like to do, I notice no clocks around here, so John, please give me time if I'm approaching, is just go through each of those phases and highlight some of the things. So first of all, phase 1A. This is, again, thinking differently. This is about focus on training and the trainee. So this is 100% direct consultant supervision throughout the whole of phase 1A. That is the requirement. So a consultant will never leave your side. We have, on average, 25 trainees in programmes each year nationally. So actually, not a huge number. That's probably about the same number as we've got just in this room here of people looking after them, and that's from one area. So how do we do it differently? Well, we created a few years ago the IBT-PHEM National Induction course. So this 1-week residential course at the National Fire Service College in Gloucestershire aims to bring together all the trainees, if we can, and give them, first of all, a week's exposure to the environment. It's an absolutely fantastic place to look at the environment. It also actually gets trainees for the first time who may well be operating in a scheme on their own in a training programme, a whole training programme for just one trainee. It gets them together, which is, you can't underestimate how important that is to them. So for you guys, in terms of things that need to be done, there'll also be a local induction. This is a training programme, so you've got to have a local induction. They need to have started their logbook. We'll talk about logbooks later on. Have their first educational supervisor meeting. There is a form for the educational supervisor meeting on the Intercollegiate Board website. Please use that one. Simple plea. And at the end of their phase 1A, there's a local assessment. It's not a pass-fail. It's just a formative assessment of what do we need for them, supervision-wise, going forward into 1B. This is the National Fire Service College, or part of it, the training ground in Gloucestershire. For those of you that have been there, you'll recognise some of these scenarios. It has its own railway. It has platforms, it has a crashed train, it has collapsed buildings, it has planes, it has its own motorway that's registered, it has its own ship. It's able to do lots of the things that make, if we're doing it for one person, we'd find really difficult locally. And we get to do it together with some of the experts from the Fire Service College together. Cheaper, more effective use of our time. So we would always promote the national induction course from PHEM as part of the training programs. Not all training programs currently use that. Some have already got existing training courses that are used for their initial training, which is absolutely fine. But this one is the one the PHEM actually runs on behalf of all the trainees. You recognise a few people on the photo. That's your first phase, your phase 1A. Okay. That 1 month, 100% consultant supervision, local induction, hopefully the national induction course, and normally then a local course, again, talking about local procedures. Phase 1B is your next 5 months. So this is where they're really now actually out in operations, whatever your operation may be, and the minimum consultant there is about 20%. So you should never go less than 20% supervision. We find that actually most people run between 30 up to as high as 80%, 90%. One's got a 96% supervision in that rate, in that phase. Just think about supervision. What we're aiming to do, and the reason we put these minimums is, minimums are a safety net, but actually think about what you're doing with your supervision during those phases. And as these senior trainees progress, how they need to actually become slightly more autonomous as they go through their training program. And that's a judgment as your faculty develops to say this person's now ready to actually go a little bit more autonomous, have a little less direct supervision, or the way that we do our supervision changes. 100% supervision while the consultant is there all the time may be great. It also may be quite inhibiting on trainees, so just be aware. Trainees in this period, please, their logbook. We're going to keep on going about logbooks. Keep on encouraging them to complete their logbook. Ian's going to talk about the workplace-based assessments, which are important to get under your belt, and to supervisors to focus on during your shifts. Look at all the phase 1 curriculum elements. Use that Excel spreadsheet to pull that apart. And unfortunately, at the end of phase 1, there is a National Summative Assessment, NSA 1, which is the Diploma in Immediate Medical Care. You will need to have had an educational supervisors meeting. A structured training report needs to be done at the end of your first phase. That form is also on the PHEM website, so please use that form. And your trainees must have had a multi-source feedback in that first 6 months. So if you're in an operation, you've got to start thinking about that and the time it takes to do, and when you're going to time it in order to get the best out of it. So there's a natural split at the end of phase 1. After those 6 months, and your second 6 months of training when you're starting as a senior trainee now to consolidate all of this. You don't have to do all your phase 1 elements in phase 1 and all your phase 2 elements in phase 2. Give you an example, part of our pre-hospital emergency anaesthetic competencies are actually phase 2 elements, but actually you're going to learn those, I imagine, very quickly in your first few weeks of phase 1. What the curriculum tells you is the earliest time at which those can be assessed. Okay? So phase 2 is your 6 months whole time equivalent. Again, minimum 20% consultant supervision, but just think of how that supervision is structured as a supervisor. And again, it's the same things we need to be doing, but just remember at the end of phase 2, a lot comes together. So they have quite a big exam, the NSA2, the Fellowship in Immediate Medical Care, which they will no doubt be furiously revising for early on. They will also have something called the Training and Assessment Panel, which I'll talk about later on, the TAP, which they need to provide a lot of paperwork for and documentation. Leaving all of those to the last minute, as most PHEM providers may well be in their nature, is not going to be good for them. So it's got to be a constant push all the way through to make sure that trainees are actually just keeping up and encourage them to make sure that they're up to date with both their TAP paperwork, their curriculum elements, and the revision for their FIMC. At the end of it, you must do a structured training report for them, same form, and they need another MSF in that 6 months. They often rotate between organisations, actually, between these two phases, but each programme is slightly different. So that is your overall progression through training, starting with your initial educational review and your national induction course, through phase 1, to your summative assessment at the end of phase 1, educational and your STR, and then moving into phase 2, with the same elements, all grouped at the end, unfortunately. So what actually we'll be teaching them? You'll get to know the curriculum very well. So the curriculum has 6 main themes for what we call cross-cutting themes, which are these ones in the centre. And each one is actually then divided into units and then into elements. And if I remember rightly, and the trainees will know, there's 1,014 elements, I think it is, something like that. So just over 1,000 elements in there that we're looking at. The curriculum, we can talk about how it's developed, but actually this is a consensus process over about 5 years from all across the UK. Okay, and this is now being used in other areas of practice internationally and for other health professionals on the Skills for Health ladder here in the UK. So it's a curriculum that Nick Foster now, as the curriculum committee, is in charge of. But I want to take you through some of the areas and some of the challenges. So all the curriculum is in that pink book. Please have a look at it. First theme, working in emergency medical systems. The challenges, I think, for there, particularly looking at having our knowledge of international models. When I say knowledge base, this is a nice, easy one to think of for exam questions, to test knowledge. And actually, we need to, as supervisors, be up to date on our knowledge. There is no one set of resources currently for this module that we can find or have been produced. But I challenge both our knowledge base and make sure they've got the knowledge base for this particular unit. The second one, providing pre-hospital emergency care, is the biggest unit. Okay, so this is the stuff probably you're more familiar with, actually more comfortable with, but it covers a lot. So don't forget, we cover all age groups, from neonates to the elderly, and at least a quarter of this is going to be around children. If you go to sections 2.4.2, 2.4.9, you'll see them in the curriculum. These are big, long sections. Essentially, there are 26, there's an A to Z, of medical presentations. This is what actually trainees struggle with. You're not going to get exposure to all of these, but you need to have a knowledge. There are other ways you can address this. You can do simulations, case-based discussions, but you need to focus on it, because this is where, at the tap, people have fell down. And there's just a lot to cover. So they really need to focus on that. So do look at theme 2 as part of your supervisors' meetings and see how they're doing with that. That should say 3, using pre-hospital equipment. One of the things we're all guilty of is that we actually just know the equipment in our operation. This isn't about our operation. This is about pre-hospital emergency medicine, the bigger picture, the wider picture, what's out there. We need to be able to convey that to our trainees, and we need to have a knowledge of some of the equipment that's out there. So that's one of the challenges actually, is when it comes to testing this in an exam, for example, it may not be the equipment in your operation. So you need to give them that focus. You may need to get extra equipment in. Supporting rescue and extrication, we all like doing this. Use your resources. The National Induction course is really good for this, because it covers a lot of the competencies, a lot of the elements around rescue and extrication in different environments, which is really difficult to cover locally. Otherwise, please just use your local heart and fire and rescue service to support you through this. Supporting patient transfers, our 5th theme. It's a really difficult area that for many programs to cover. And that's because lots of this talks about inter-hospital transfers. Okay, it's not something that may be familiar to your operation. If it's not, it needs to be in there for the trainee. This is about the trainee and the training, so we need to make it happen for them. How do we make it happen? Is this a secondment out to a paediatric retrieval service? Is this EMRS and EMRTS are both set up in a way to do these sort of things? That's great. Secondment's there. How do you make this happen in terms of the transfer world? The final big clinical theme is our supporting emergency preparedness and response. Our biggest challenge we found trainees have had over the last few years has been around Silver Command, the tactical command courses. And that's getting better. We're getting some courses up and running for that, and ran a course last year. There are 4 other cross-cutting themes. We don't often pay attention to them. Please, this is at the very end of the curriculum and at the bottom of the list for trainees, and often at the bottom of their thought process list as well. So there's lots of clinical governance activity in there. There's other operational activity, even stuff about CAA and driving and so on. So it needs to be in there in your thought processes. Do get to the bottom of that list and have a look at them. The opportunities come from what is in your programme, but there are other opportunities that we can provide. So there's national training days. So your TPD should have a list, and Matt Thomas from South Western 7 is coordinating this, of the opportunity for other training days in other areas that are opened up to trainees. These aren't compulsory. These are just an offer of training, so I don't think they are. But they are great experience, and each area is covering something different. Regional training days. If you've got a programme of 1, you still have a regional training day. But please focus your regional training days. A specific day set aside with no service commitments that focuses on your training and a particular theme, elements that are difficult to cover, particularly the knowledge base. There may be other training that you can find locally within your area, whether that be your local air ambulance, your local ambulance service, the local university, trauma centre, and so on. But please make the most of the training opportunities, and remember this is about actually achieving the elements of the curriculum in these 3 phases. Hopefully, if you put all that in, that's a quick overview there, your trainees should get the most out of it, and actually as supervisors, I think you'll get a lot out of it as well. Thank you very much.